Next question.
Thank you. This is for Dr. Spencer and the panel that kind of keys into what you've been talking about. All. If we decide that creating a medical home is a desirable thing, how do we change current physician-provider behavior, the kind of behavior that's described in the book, How Doctors Think? How do we change that behavior when physicians and providers are paid by most payers for a 14-minute encounter?
Before we go away, can I ask you a question? And this is my curiosity. What brought you to this meeting? Are you in the insurance industry? Are you a legislator? You're just a
At this point in time, I would probably describe myself primarily as a consumer of health care. Coming from the background of being a physician, having been a policy analyst for a bit, I now wonder how we're going to move this transition.
Right, thank you.
Actually, before you go, I want to make sure I understand the question. Your question was, how do you change provider behavior?
How do we change current provider, physician behavior, the kind of behaviors that are described in the book, How Doctors Think? That is, you see the patient, you listen to their chief complaint, and you reach in your mind a decision about what's wrong and what you're going to do about it within several minutes or not seconds. And then the rest of that 14-minute encounter is built around that. The kind of encounter you've described, taking 30 minutes, isn't paid for by most payers in the current system.
Excellent question. I think group health's in this unique, or at least our pilot was in a unique position of having not to code high or have RVUs in order to have an income or to make it viable. So our responsibility to patients is to make sure that we had really worked on patient relationships, that we provided access, that we could really get them to the right place of what they needed. The challenge of a medical home model, I think, within any practice is a lot of physician behavior changes. So I think clinicians are really used to being authoritarian and telling patients more or less what they need. The transformation here was actually working with patients to identify what their goals were. And let me bring up just an example. For some chronic diseases, we've developed a care plan. This is something that nurses do all the time, but physicians absolutely don't, and didn't even know what this was about. But basically, this is a plan with the patient of what their goals were, who their team was, what their illness was, what it was doing to them. And then we printed this out in something we called an after-visit summary that they could tape on their laundry room door. So that the physician behavior is not the lose 10 pounds. The physician behavior is, what is your goal? How can we help? What's realistic for you? What do you want to do? So there was a lot of empowerment of patients and physician teaching of how to motivate that. I don't know if that answers the question.
I'll respond as well. I think the way you change behavior is by changing the environment in which physicians and other providers practice. You have to change the structure of the system in order to drive the right kind of behavior. I'm a firm believer that most people who go into healthcare have good intentions and are smart people and are well-trained and are primed in most cases to do the right thing, but you put a most excellent person in a really bad system, they're going to perform very poorly. If you align incentives adversely, they're going to do the wrong thing. So what we've done at QLions is tried to reset the system in a way that sets people up for success, so that maybe you can take even moderately good physicians and make them great. Wouldn't that be a great innovation? Rather than putting all the burden on physicians to be superhuman in their abilities. I mean, to sit down with someone for 7 minutes, listen to them and figure out what's wrong with them, and not jump to conclusions, not make snap judgments, not do the wrong thing, not over-test and over-treat is, wow, you gotta be pretty much psychic to do that. But that's what we're asking physicians to do every single day when they rush through these visits with patients. So instead, why not reverse the setting and say, we're going to give you plenty of time to talk to your patients. And if you need more time than that, you take more time. If you need to see them again tomorrow, you do that. You talk to them on the phone, you do it by email, whatever you have to do. Listen to the person, ask them questions. My history-taking skills took off when I got to QnA because all of a sudden I had time to ask questions. I got curious again. I really wanted to know about my patients. And by about 6 months into this, I woke up one day and I said, I am a totally different doctor now than when I started out. My brain is working again. I'm using my intellectual faculties that I was trained to do, you know. I would argue that our medical education system needs to change too, but largely it does train you to think. And then you're thrown into an environment where thinking costs you. It's a bad idea, don't do it. Think in terms of protocols, think in terms of reactive care. Test and treat as much as you need to do so you can move on to the next person. All the incentives in the current system are in line to make you do that. In our system, not only am I incentivized to think about it and do the right thing for the patient and involve them in their care and listen, I work for them. So if I don't do that, they fire me. Literally. I know every month who my patients are, and I get a notice if someone terminated their membership and why. And if it was for any reason that I can do anything about, you've got to know I'm going to try to do something about that because I'm incentivized to have a nice, stable population that continues to pay their monthly care fee month after month. I think that ultimately it's an old-fashioned concept to have you actually work for your patients. Whoever pays your bill is the person you're working for. If you're an attorney and your client pays your bill directly, you're going to work hard for that client. It's just, that's the nature of the beast. That's how things work. And so why not harness that energy in favor of really good care? The results are dramatic, and our patients give us tremendous feedback on this, that they feel like they've been listened to for the first time in a long, long time. And I'm not saying that physicians and other providers are bad in the rest of the system. I'm saying the system is bad and it drives bad behavior. So in answer to the question, change the system. You've got good people there, they're going to do the right thing, including the patients. I think the patients are rational actors and they're going to do the right thing.
But I think in both these systems, there was a prepayment and then there was incentives aligned with physician behavior compared to the real world for most of us where it's an insurance company paying us and you only get paid for the encounter with the patient and there's no incentives so far with Medicare and a lot of the other insurance companies, even though Primera is trying to align our incentives to seeing the patient less and communicating via email and getting a team approach. And that's going to be the crux of this medical home. Next person, if you could just tell us about yourself too, that would, just for my curiosity.
Okay, I'm going to take 20 minutes to tell you about
myself.
I'm Paul Guppy, I'm the research director at the Washington Policy Center.
Okay.
And the president has announced that this is a big year in healthcare policy. In fact, he set a kind of a deadline for Congress and that he'd like to see legislation coming out of committee by August to create some form of national healthcare plan. And each of the panelists has described a different aspect of new trends in healthcare. So I wonder if each of you could just briefly tell us how you see the particular topic that you talked about, the trend that you talked about in healthcare, and how that would be affected or how it fits into President Obama's plans for creating a national system. So would it end or eliminate the activity that you're doing? Would it make it better? Would it become part of the national system? Or just what do you see as the future for what you described?
I guess I'll start. Well, first of all, I know that one of the big pieces that has some momentum is to offer the public sector plan to the private sector. Now, the big question is at what price and what does it cover? The other big piece is to eliminate the tax incentive potentially for employers to offer healthcare plans. Because the government right now feels that they spend a third, or they're purchasing a third of the healthcare system today in addition to the 50% they spend on Medicare because they're letting employers deduct a third, which is basically the deductibility of healthcare. So now, against that, so it may take the employer entrepreneurialism out of it if you've got a program that's just going to be far less because of the way that they pay providers. It's very different than the way the private sector does, and depending on the area, 30% less. However, what they're also saying is that they want to encourage wellness. And I think that that's going to be interesting to see how they do that, and what's the measure going to be. They're discussing it, but I think what's lacking so far is a lot of details. But I do think that if the public plan does come, I think it's going to legislate and basically dictate to all of everybody what they're going to be paid. It's still a fee-for-service model, and I don't know that much more than lip service will be played around what true wellness and management may be. It's my opinion.